Hello, my name is Dr. Donna Ryan. I am Professor Emerita at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. And what I'm going to talk to you about today is a sub-study that we did, the very first sub-study from the real landmark SELECT cardiovascular outcome trial. And so this is an analysis of weight effects in SELECT. You know, we have twin epidemics. We have an epidemic of obesity. It's really a global epidemic. Of course, our obesity rates are highest in Western countries, but they really are, no country is immune from the effects of obesity. And cardiovascular disease is our number one killer. It is responsible for 1 out of 3 deaths globally. So we've been pretty successful in developing approaches to managing cholesterol and other lipid disorders, to managing blood pressure, to smoking cessation, and to coagulation, managing coagulation to reduce cardiovascular risk. But we've never really had an approach to weight loss and weight loss maintenance that has been shown to have a positive effect on reducing cardiovascular risk. So what's important about the SELECT study is that it's a cardiovascular outcome trials in individuals with overweight and obesity who are at very high cardiovascular risk. They've all had an MI, a stroke, or peripheral artery disease. And they were treated with either semaglutide or placebo, and we observed a 20% reduction in subsequent cardiovascular events, either an MI, a stroke, or a cardiovascular death. This is important. We've been able to show that the medication that we're using for obesity here, we've been able to show that medication reduced cardiovascular risk in people with diabetes. But none of these people in SELECT had diabetes. This is strictly a medication that's indicated for weight management in individuals without type 2 diabetes. It's not really about managing glycemia. It's about losing weight and keeping it off. So it's really a landmark because it shows that we have a treatment for obesity that can really have an impact on reducing cardiovascular risk. The primary outcome is so spectacular. The first cardiovascular risk reduction trial in obesity. And, that's what everybody loves and is so excited about. But the results of this sub-study are really pretty spectacular too. When we evaluate medications for weight management, we do it in a weight loss study. We're giving people instructions on how to change their diet and change their physical activity to lose weight. This study was a heart disease prevention study. We didn't use any dietary attempts in our patient population. It was all about managing your cholesterol, stopping smoking, and really all of the approaches that we know work in heart disease prevention. So it wasn't a weight loss study. And so what this study does is it gives us a lot of data in a very specific population, in an older population. Our weight loss studies are usually done in a younger population. This, of course, everybody in this study had heart disease, so they were naturally older. And it's also a sicker population. So we exclude people who have heart disease from our weight loss studies. They were not excluded here. They were selected. It's a large population. It's 17,604 patients, older, a little bit sicker, many more men than we're used to seeing in weight loss studies. So a lot of new data that really enriches our experience with using semaglutide for weight management. So, when we take our medications to the regulatory authorities, we have a series of studies called phase 3 studies. And the phase 3 studies generally have about 5,000 people in them. They're about half on the medication, half on placebo. So in this study, it's a huge enrichment in terms of numbers. And it's a very important population, an older and sicker population. So I think that's what's the value in this analysis. Yeah, so let me tell you what we observed. First of all, we saw that we got almost as much weight loss and the same pattern of weight loss that we do in our weight loss studies. So people lost weight over about a little more than a year, and then the weight was maintained, and it was maintained for a long time, for the full 4 years of observation. Our weight loss studies were only 2 years. So having this data on efficacy and safety for 4 years is wonderful. Large population, 4 years of observation. The weight loss was almost as much as we observed in our weight loss study. It was roughly 10% from baseline on average. Those patients who were on drug lost a little more than the intention to treat population. The average weight loss we observed in patients who were enrolled in the study, but may have stopped the drug for side effects or whatever. So we did see slightly less, about 1 to 3 percentage points less weight loss. And we think this is because, first of all, this wasn't a weight loss study. Patients were trying to lose weight. And second, because we didn't really push the dose of drug as much as we do in our weight loss studies. So there wasn't as much drug exposure, but still very robust weight loss, more than 10% weight loss. And everyone who has obesity or overweight likes that. So the very first and important thing is that we saw robust weight loss. We saw durable weight loss, 4 years of durable weight loss. And every subgroup we looked at seemed to benefit. So men and women both lost weight, clinically significant amounts of weight. Women lost a little more weight than men did, by the way. We think that's due to the fact that they had greater exposure to the drug dose. And then all around the world, all countries and individuals of all races and ethnicities lost clinically significant amounts of weight. Whether you had prediabetes or not didn't matter. You lost the same amount of weight, whether you had prediabetes or had what's called normal glycemia. So it also the weight loss among people of different body sizes was very interesting. So we saw that individuals who had a BMI of 27 up to 30, that is the overweight category, that they lost less weight on average than the individuals whose BMI was greater than 30. You would expect individuals with that lower BMI perhaps to lose a little more weight because they would have more drug exposure. But we think that the reason they didn't is sort of a mathematical explanation. In other words, if you start nearer to your plateau weight, where your weight is going to settle out over time, that of course, proportionally, the percentage of weight loss will be less. So that, all in all, very reassuring to see that robust weight loss in all categories. Very, very good. The other thing that we observed was that there were really no difference in serious adverse events based upon body size, and that's also good. We did observe that individuals with lower BMIs did have higher rates of stopping the medication, and the reason for that is, of course, if you were in a lower BMI category, if you had a lower body size, you had greater drug exposure. So you would presumably have more of the side effects of the drug. But still, the tolerability of the drug was similar to what we see in our weight loss studies, and our safety. There were no surprises. Everything we know about this medication, or what we expected. We expect nausea and vomiting as a tolerability issue. But there was no signal about pancreatitis, and all in all, very, very reassuring. So I was delighted to present the efficacy and safety results around weight loss with semaglutide versus placebo at the European Congress on Obesity. I think everyone was glad to see that this data confirms that this medication can produce robust weight loss in all categories of people, older, younger, even those with established cardiovascular disease. So we were very happy to present these results. I think what these findings do is they really enrich our knowledge about how to use semaglutide 2.4 milligrams subcutaneously in our patients who need to lose weight for health reasons. So it gives us a lot of confidence around using the medication in all types of people, in old and young, in women and men, in people of all races and ethnicities, in people of all body size. So I think what this really does is it adds to our knowledge about the efficacy and safety of the drug. We all need to recognize these are powerful and effective medications, and we need to be knowledgeable about their side effects and safety issues. And I think we have a very good database to inform us on safe and effective prescribing. We want the cardiovascular risk reduction that we observed with semaglutide to be the same across all classes of GLP-1 receptor agonists. That's what semaglutide is. But we need to wait. We need to wait and see what the other cardiovascular outcome trials show. So this is wonderful, exciting results around semaglutide. We want to see studies and we want to see research that demonstrates these results can be achieved with other medications in this class. Thanks very much for inviting me to talk about the SELECT trial, semaglutide in patients with established cardiovascular disease. It's my very great pleasure. I had a great time at ECO, seeing all my friends and colleagues, and I hope that they're listening to this and agree with what I'm saying.